National Institute of Cardiovascular Diseases, Dhaka. She is also the International Affairs Secretary of BSRI. Dr. Fatima Doza Madam will deliver MRI in breast neoplasm, PERS and pitfalls. And due to some unavoidable situation, she has to leave the webinar early. So I'd like to request Dr. Fatima Doza Madam to start the talk, please.
Yeah, thank you very much. Can you see? Can I see?
Yes, yes,
Yeah,
it's visible.
so it's visible. So
Yes.
start. Respectable delegates and today's learned audience. Welcome. Today I'm talking about MRI in breast neoplasm, first and pitfalls. The learning objectives will be indication of breast MRI. At the end of this session, we'll be able to know about the protocol, the MRI characteristic of breast lesion and analysis, first of MRI breast, pitfalls in MRI breast. So what are the indications of breast MRI? It is for the detection, evaluation, staging of the cancer and the management of the breast cancer patients. We do MRI of breast. Screening for breast cancer in select high-risk patients. Who are the high-risk patients? The high-risk patients include, those with a family history of breast and ovarian cancer, high-risk pathology such as lobular carcinoma in situ, ADH, radial scar, and women who have a history of radiation treatment. We do MRI for evaluation for multicentricity or bilaterality of a known cancer. We do MRI for determining the efficacy of neoadjuvant chemotherapy. Differentiation of scar tissue versus recurrent neoplasm in patients who have undergone breast surgery, MRI is a very useful modality. Evaluation of patient with metastatic axillary adenopathy with an unknown primary. It is very problem solving for patients with dense breast tissue. Those patients a physical exam and equivocal finding in ultrasound or discordant pathology result. In these cases, MRI is very useful. Patients with breast augmentation and reconstruction, we do follow-up. In case of occult primary breast cancer recurrence and characterization of equivocal finding, we do it. So MRI of breast is increasingly used to screen for breast cancer in the high-risk patient. There are many factors used in the determination of patients' overall relative lifetime risk of breast cancer. Breast cancer risk factors include a family history, the ovarian cancer, the high-risk pathology such as lobular carcinoma in situ, the atypical ductal hyperplasia, radial scar, and I have mentioned women having a history of radiation treatment for Hodgkin's disease. So what should be the protocol? In some states and in some hospitals of US, they follow the protocol as follows. Bilateral morphologically study using bilateral unenhanced high spatial resolution, T2-weighted fast spin echo sequence without fat saturation. We take it in axial plane, bilateral 3D gradient echo, T1 weighted dynamic sequences in axial plane with or without fat saturation according to the radiologist, what he or she wants. The thickness should be between 2 and 3 millimeter according to the breast size, spatial imprint resolution less than or equal to 1 millimeter square. What is the dose of the intravenous gadolinium chelate? We used standard dose of 0.1 millimole per kg with an injection rate of 2 ml per second. And we do then saline flushing using an automatic injector. For dynamic studies, we perform both with and without fat saturation. The images post-processing include temporal subtraction, morphological in addition to dynamic analysis. We do analyze the curve, time intensity curve. These are all performed on native images in incidences of patient motion. What is the protocol for ACR? American College of Radiology has established minimum standards for breast MRI accreditation. The standards include a T2 weighted sequence, multi-phase T1 in accordance with the ACR standard. Both breasts must be examined simultaneously. Acquisition during a pre and post contrast T1 weighted sequence must have a slice thickness I have mentioned previously, less than or equals to 3 millimeter. There should be no gap, and the maximum in-plane pixel dimension for phase and frequency should be less than 1 millimeter. T1 weighted gradient echo imaging should be performed quickly with dynamic enhancement as well as delayed imaging enhancement. So you can see this is the pre-contrast phase, this is the post-contrast study, and this is the subtraction, fat and gland subtraction to see any pathology within the parenchyma. So evaluation of images and lesions should be based on several factors. The most important factor is to analyze the enhancement characteristic and morphology. Delayed imaging is beneficial in some cases, such as ductal carcinoma in situ. And we might include T1 and T2 weighted open field of view sequence to evaluate the chest wall and other surrounding soft tissue. So you can see we have FOV, we have included the chest wall, we have included the mediastinum. So a patient with a breast cancer, there is some metastasis in liver and there is a mediastinal lymphadenopathy. Comparative studies have shown in several studies that breast MRI has about, in some specificity as mammography and a significantly higher specificity than breast ultrasound in some research. This is the case. So audience, can you please tell what is this case? So this is I will tell later on. In the beginning, I have put the cases because at the beginning, whether you can do, and at the end of the presentation, whether you can do. So is it normal? Case 1, this is the fat subtraction, and this is T2 weighted image. Okay. This is the case 2. You can see the subtraction, the enhancement phase, and the T2 weighted image. So what type of lesion, you can ask yourself. Case 3. This is a lesion in T2. This is the post-contrast enhancement, whether it is benign or malignant. Case 4. This is a hyperintense lesion, that is the T2, and this is the subtraction. Case 5, subtraction, T2 weighted image. Is there anything or they are normal? So in breast MRI imaging, there are some terms we need to put. The terms are mass, non-enhancing mass, and focus. What is a mass? It is very special in breast MRI. A mass is a three-dimensional space-occupying lesion measuring more than or 5 millimeter. It is usually visible on pre-contrast T1 weighted or T2 weighted image. It constitutes the most common MRI lesion in a study. They have designed that the prevalence and predictive value of MR features there was about 62.7% were the masses. The masses are the space-occupying lesions. They are both benign and malignant. Typical causes of mass in breast cancer: fibroadenoma, papilloma, fat necrosis, atypical forms of benign proliferative breast disease, sclerosing adenosis, inflammatory lesion, and intramammary lymph node. So both benign and malignant are the mass. So what is the characteristic of a benign lesion? Usually, they have a smooth margin, very well defined, and sharply demarcated border. They may be round or oval shaped. There should be homogeneous enhancement within the mass. This is highly suggestive of benignity in tumors more than 1 centimeter. However, what happened in the smaller tumor? The reliability of the finding is lower because the spatial resolution may limit the evaluation of the small breast cancer, usually have a homogeneous content. So that is the pitfall. So these are the images. You can see a 48-year-old patient with a suspicious ultrasound finding in left breast in the 12 o'clock position. This is the pre-contrast T1 weighted and gradient echo image. This is the RD post-contrast. This is the subtracted image, and this one T2 weighted non-fat subtraction image. The lesion is invisible on the post-contrast. This is the post-contrast. It is not visible here. And because of the absence of enhancement, the round mass, this is the round mass. These are on the pre-contrast T1. This is the subtraction post-contrast. This is invisible. And with smooth margin in the pre and post-contrast, non-subtracted images, and the low signal intensity lesion in T2 weighted image. So this is a benign lesion. Why this is benign lesion? Number one, very well defined, the shape without any architectural distortion or mass effect, and the enhancement pattern. There are some other characteristics in MRI of breast imaging. The fat tissue, fat content within the mass, they should be investigated in T1, T2 unenhanced sequence without fat separation, which gives a hyperintense fat. I will show some cases. Fat content occupy a part of a mass is specific to benign lesion, that is hematoma, fibroadenoma, intramammary lymph node, or fat necrosis. So you should keep in mind that without fat separation, we should do unenhanced T1 and T2 for the search of benignity of a lesion. There are some other characteristics. Very strong hypersignal on non-fat suppressed T2 weighted sequence. This is classically considered to be a clear sign of a fibroadenoma. However, this finding has recently been questioned with T2 hypersignals described in several breast cancer, predominantly mucinous carcinoma, invasive ductal carcinoma, metaplastic carcinoma, and intracystic papillary carcinoma. In a neoplasm on T2 weighted sequence generally does not have a homogeneous hyperintense sequence, whereas in fibroadenoma, the hyperintense signal is homogeneous, except where there is a thin septa. Homogeneously high signal on T2 weighted sequence and homogeneous enhancement highly these are the images, well circumscribed lesion, and you can see there is a well circumscribed lesion in pre-contrast T1 weighted gradient echo. Here is the RD post-contrast, and this is the subtraction image. And you can see very well defined. But in addition, what have we done? We have done time and intensity curve analysis. So whenever there is a pitfall of MRI, that is whether the lesion is a mass The lesion is very well defined. The lesion shows almost homogeneous internal enhancement, but the lesion shows very rapid and steep rise and very fast enhancement, very early washout, and then goes without forming a plateau. This time intensity curve shows this is a exception. That is, this is a malignancy. So what about rim enhancement? Although rim enhancement regarded as suggestive of malignancy, a regular enhanced rim, which may be thick, may be around the cyst, seroma, and circumscribed fat necrosis. Differentiating this entity from a malignancy is based on mass content assessment. Mind you, how we differentiate rim enhancing benign lesion from rim enhancing malignant lesion. We can assess the mass content assessment with a strong and hyperintense fluid-specific signal, that is for cyst, seroma, a fat-specific signal, which is circumscribed fat necrosis that indicate benign lesion. And the malignant lesions are thick wall and irregular enhancement and heterogeneous. So there are some enhancing focus and a proteinaceous cyst, a 42-year-old patient with adenosis and fibrocystic changes. This is the pre-contrast evaluated. This is the gradient echo, post-contrast image. This is the post-contrast subtraction. This is the tiny lesions, and too small to characterize. And these are the tiny lesions. And extremely dark signal on this lesion on T2-weighted image. This lesion does not show extremely dark signal, rather a tiny cyst, but this is an extremely dark signal. So these are all cysts, but this is a proteinaceous containing tumor or proteinaceous neoplasm. Previously, I have told rim enhancing benign lesion. These are the rim enhancing benign lesions with fat level and fluid level, very regular, well-defined enhancement. And there are another regular. Why I have called it regular? Because there is no mass effect. Here there is no mass effect. Yes, and after the contrast, this enhances. And these lesions are duct ectasia, complicated cyst and duct ectasia. So I have shown another important parameter of MRI, that is enhancement kinetic. What is enhancement kinetic? For analysis of enhancement kinetic, we look at how fast a signal intensity increase appears in a lesion after contrast injection. This is a curve, this is the time, and this is the signal intensity. And this is the peak of the lesion. So the lesion shows very fast contrast enhancement within a short period of time, and intensity is highest, and then very rapid washout. These spatial criteria goes for malignancy. And usually there is also exception, delayed and increasing enhancement, delayed washout time, and with or without plateau, this time intensity characteristic is usually for benign. What about the scar enhancement or recurrence? It is the most common question of the surgeons, of the oncologists after operation, after chemotherapy and radiotherapy. So after major breast surgery, scars may exhibit contrast in how long? It may persist up to 6 months. In individual cases, however, this may vary considerably. In women with complicated wound healing, enhancement may persist more than 6 months. And other women do not have any enhancement at all, only a few weeks after surgery. In any cases, enhancement of scar should not provoke serious differential diagnostic problem, that is to be a residual neoplasm or to be a recurrence. This is because scar enhancement is relatively subtle and occurs more or less evenly in the entire scar. This is the contrast to recurrent cancer. Recurrent cancer do not occur subtle, or they do not occur in even distribution within the scar, and that is uneven. So another point is the recurrent carcinoma always exhibit a mass effect within the scar and causes focal enhancement that is confined to a part of the scar. So a scar may usually show homogeneous enhancement, but a recurrence may show mass effect as well as focal enhancement. Accordingly, even in the early post-contrast phase, breast MR imaging can be safely performed to distinguish scar from recurrent or residual breast cancer. So what about the correlation with mammography and ultrasounding finding? The mammography and ultrasound finding are usually useful in confirming lesion benignity. Masses more than 1 centimeter are generally found on conventional examination, and decisions on the need for biopsy should be made according to the finding of examination, showing the most suspicious feature. Only the MRI feature should not be a base for a management plan. In some cases, the pattern of imaging differs. The rapid and strong fibroadenoma enhancement, it is a common finding. It is an exception, and that is the pitfall in premenopausal patient. So there is a well-defined mass which shows very rapid enhancement, very rapid washout. Instead of being a cancer, it is a benign lesion. Why? In cases of premenopausal patient, it gives a false positive cancer diagnosis. Moreover, the smooth margin and benign morphology of a mass should be considered with caution in patients with BRCA1 mutation because they are high-risk patients. I have told one pattern that is a mass. The mass belongs to benign as well as malignant. There is another pattern of imaging in MRI called non-mass-like enhancement. What is the non-mass-like enhancement? It refers to non-enhancement of an area that is neither a mass nor a focus. The enhancement pattern is distinct from that of normal surrounding tissue. There is no space occupying effect or there is no mass effect, and the lesion is not seen on unenhanced sequences. That is a non-mass-like enhancement. So what are the causes of typical non-mass-like enhancement? They are benign condition as well as cancerous condition. The benign conditions are mastopathic change, due to hormonal stimulation, inflammatory change, and the malignant one, ductal carcinoma in situ, invasive lobular carcinoma, and some cases of estrogen receptor negative invasive ductal carcinoma. Non-mass-like enhancement is the major cause of false positive breast finding. It is the great pitfall of MRI. So we must have in our mind that a small lesion and non-mass-like enhancement, it may be a cancerous thing. In patients with a non-mass-like enhancement, seeking benign lesion criteria may decrease the false positive rate. In patients with a non-mass-like enhancement, I have told, there should be bilateral symmetrical non-mass-like enhancement, which is highly suggestive of benign change. There may be presence of cyst, which suggests benign change like fibrocystic disease. And this is a case of mass-like enhancement pre-contrast. This is the early post-contrast, and this is the subtraction image. And you can see that this is a 49-year-old patient, and she has in the early post-contrast, this is the non-contrast, and this is the early post-contrast. Early post-contrast you show ill-defined, without any mass effect, non-mass like enhancement. But eventually, this shows irregular, non-mass like enhancement. And this is a case of mastitis. But in some cases, this may be a differential diagnosis, that is ductal carcinoma in situ or lobular carcinoma in situ. So there is another pattern of enhancement in breast MRI that is called the diffuse enhancement. This is a good indication of benign changes where there is a lack of clinical, ultrasonographic or mammographic sign, and diffuse breast neoplasia within the entire breast parenchyma generally display clinical, mammographic or ultrasonic sign. Diffuse enhancement may be localized to a breast in a non-menopausal patient with a history of cancer in the contralateral breast in which physiological enhancement has been impeded by radiotherapy. So it is very important. When we have given a radiotherapy, there is a subtle non-enhanced cancer which may hide within the physiological enhancement of normal breast tissue. There is a pattern we should follow in breast MRI imaging analysis. What is that? That is the distribution of the lesion, the internal enhancement pattern of the lesion, very important in BI-RAD lexicon. However, their accuracy in distinguishing benign from malignant lesion in localized enhancement is somehow debatable. A lesion is likely to be benign where there is localized enhancement that is both regional in terms of distribution rather than ductal or segmental. Whenever we call that is, it is inner aspect right upper quadrant, and that is the regional term of distribution and rather than ductal or segmental. And stippled, composed of multiple enhancing dotted foci in terms of internal pattern. And when it occurs in a non-menopausal patient without strong risk factor and any supporting abnormality noted in mammography or ultrasound image. We should be careful about that. So there is another type of lesion in breast MRI we call focus. We have told mass, we have non-mass, and we have told focus. A focus is a tiny enhancement dot measuring less than 5 millimeter in size. It is not a space occupying lesion. There is no mass effect. A focus is usually due to benign lesion, such as papilloma, fibroadenoma, intramammary lymph node, or focal fibrocystic change. But their syndrome represent a focal, tiny invasive cancer or ductal carcinoma in situ. So this is the chart of enhancement pattern suggesting the benignity, and negative for MRI, the mass, and this is the MRI follow-up by RAD-3, and how the mass, the cyst is contained, lymph node, fat necrosis, the non-mass, bilateral and symmetrical, numerous T2 hyperintension cyst, and focus, multiple or bilateral single no washout, that is negative MRI by RAD2, and follow-up smooth border plus homogeneous enhancement, diffuse unilateral enhancement. This is a non-mass-like lesion, and regional patchy enhancement with stipple pattern may be present. The most commonly accepted reporting system for breast imaging is BI-RAD classification, and there are identical to the mammography. The 0 is incomplete, 1 is negative, 2 benign, 3 probably benign, 4 suspicious abnormality, 5 highly suggestive of malignancy, and 6 known cancer. So now for very important factor, that is for full lesion features and description. The term we have already I have explained. These all terms and these features, this description of MRI, the ACR website has a MRI lexicon classification. That is very important. I have not put it here. So what are the pearls in breast MRI? Contrast enhanced MRI of breast has shown relatively high sensitivity, ranging from 94 to 99%, for invasive cancer and 50 to 80% for in situ cancer. That is very important. MRI has been shown to increase the sensitivity in the evaluation of loco-regional disease involvement in the breast, axilla, chest wall, and other organs. When combined with mammography, ultrasound, and clinical exam, the sensitivity of MRI is as high as 99% in cases of newly diagnosed breast cancer. So this is a very good thing about the MRI. So another part in a MRI, um, there is a lesion in left breast. Sorry, I have seen in uh, upper and outer quadrant of left breast. We can see there is a lesion. Okay, and what about this? Is the post contrast image. This is the color coded image, and the same patient post image. See that there is the lesion that is visible in the mammography. There is another lesion which is not well delineated in the mammography. And this is the color coded image. So in mammography, we suspected one lesion, but in breast MRI, we found the lesion involved both the breast. Overall tumor size is more accurately depicted on MRI compared to mammography when correlated with pathology specimen. This is the mammography of a patient with a dense breast. We cannot see anything. Ultrasound of this patient shows a hypoechoic mass lesion. And this is the MRI. The extent of the lesion is clearly depicted. This is the extent of the lesion, invasion of the lesion. It is more accurately depicted in MRI. So another part of MRI is excellent in demonstrating effect of neoadjuvant chemotherapy. Nowadays, breast conserving surgery is very popular. So after diagnosis, neoadjuvant chemotherapy is given. And after that follow-up, breast MRI is done. You cannot see the lesion, or there is a faint blue lesion which is significantly decreased. This is a case, another case. This is the right breast, left breast, and after neoadjuvant chemotherapy, then we can see marked reduction of size of the lesion in both breasts. So it is the pearl. There are some problems when we cannot decide whether the mass is present or not. This is a mammography of a patient, initial mammography. It is about to normal. And after 6 weeks, or there is a marker in her left breast, and there is linear speculation. It is suspicious, plus minus. And the ultrasound was done. There was a mass. And in MRI, we can see two masses. So the problem solving discordant things, the MRI is very, very rewarding. In case of dense breast, we face very problem. And this is another patient. There is a suspicious lesion here. In ultrasound, there is a hypoechoic lesion, an oval, and MRI, we got rim enhancing, strongly rim enhancing, irregular, thick rim enhancing lesion with mass effect. That was a carcinoma. A patient with nipple discharge, we could hardly found any abnormality in mammography. And when the ultrasound was done, and then irregularly dilated ducts, and there is hypoechoic filling defect, hypoechoic masses in some part. And when MRI was done, there are irregularly distributed, irregularly enhancing lesions. What are the pitfalls? I have already discussed few of them, and MRI is less sensitive to detect the low-grade DCIS. I have told why. Due to lack of enhancement, mammography, on the other hand, may detect low-grade DCIS as amorphous calcification or small foci of architectural distortion, which may not be detected or be very subtle on breast MRI. Although breast MRI is more sensitive than mammography or ultrasound, false positive findings on MRI are common. Therefore, surgical decision should not be based solely on MRI findings. The pitfalls are false negative diagnosis in breast MRI in female with risk factor. Two-thirds of the non-enhanced breast cancer were DCIS. And there is a factor that is tumor angiogenesis and possible lack of enhancement in invasive breast cancer more than 5 millimeter in diameter is rare and more difficult to explain. In particular, this has been observed in cases of inflammatory carcinoma. It has been hypothesized that these tumors obtain through diffusion and not from genuine tumor vessel, which would explain their lack of contrast enhancement. In the management of lesions that are suspicious on mammography or ultrasound, that is BI-RAD 4 or 5, that breast MRI is not useful because lesions cannot be classified as benign based on the results of a normal MRI. So that is a great pitfall. Another pitfall here. So there is a lobular carcinoma in a patient, 53-year-old patient. This is the peak contrast, and this is the post contrast. This is the post contrast subtracted image, and you can see the non-mass like enhancement. Yes, that is the non-mass like enhancement, and the time signal intensity curve. This is an exception, and it put the breast MRI in a dilemma. That is, it doesn't show the steep rise and rapid washout, rather very slow rise and slow washout and reaching plateau and then downstairs. But it is a lobular carcinoma in situ and malignant counterpart. So there is another thing is that some of the fibroadenoma being benign, the enhancement pattern shows steep rise and rapid washout. This may lead to false positive cancer diagnosis. So only with the breast MRI, we cannot make a decision for the surgical plan or plan of management. Some other terms are there: breast cancer with no enhancement, missed enhancement. This is the enhancement, and we cannot see this enhancement here. The lesion is actually this much elongated. Another portion, missed enhancement. Here we cannot see any lesion. Here we cannot see any lesion. These are the missed enhancement. So this is another pitfall of breast MRI. And misinterpreted enhancement. This is the normal glandular and normal parenchymal vascular enhancement pattern. It should not be misinterpreted with malignancy. There is an ongoing screening debate. What is the debate? Whether should we do a mammography, whether should we do MRI. Actually, mammography is the gold standard, and MRI increases the sensitivity of mammography. And indication of MRI I have mentioned earlier. So the take-home message is, as still early detection saves life regarding breast cancer, breast MRI has proven to be a valuable tool in the diagnosis, workup, and management of breast cancer. Common indications include screening for breast cancer in selected high-risk patients I have mentioned earlier, problem-solving cases, evaluation of multicentricity or bilaterality of a known cancer, determining the efficacy of neoadjuvant chemotherapy, differentiation of scar tissue versus recurrent tumor, and evaluation of axillary adenopathy with an unknown primary. The clinical indication will likely continue to expand as clinical trials demonstrate additional benefit of MRI in breast imaging. And when used in conjunction with mammogram and ultrasound, this useful tool will assist in decreasing morbidity and mortality associated with breast cancer. Thank you very much. Thank you for your patient hearing.